Which changes can you expect in nevi? Well, the good news, most nevi, if you monitor them for 1 year or for a certain restricted period of time, they will not change at all. They will remain stable. So you can differentiate between malignant neoplastic change and the nevus. Exception, children, of course. So we do not monitor children with digital dermoscopy because everything changes. Why do we need follow-up? Most of the time to confirm the diagnosis of a melanocytic nevus. Changing nevi, yes, there are, of course. In children, symmetric increase in size. You see the peripheral rim of dots. This is very typical. Sometimes also another change without the peripheral rim of dots. But the pattern is the same. Usually we excise these lesions because there is some asymmetric increase in size. And also in elderly patients, we see involution. The nevus disappears. It fades gradually. Not regression, involution. This is not an active process. This is involution. Which lesions should be monitored? An important question. Well, which lesions should be examined with the dermatoscope? Nearly every lesion. If you want to catch an early melanoma, you cannot look only at the ugly ducklings, because maybe there is somebody within the sample who looks very innocent, but he may be only innocently looking and maybe the bad guy. You don't know. And the consequence of what I've told you is that you should monitor only flat and small lesions, because we want to pick melanomas when they have no features of melanomas. So you should monitor mainly flat and small lesions, because an early melanoma will be in that part of the timeline, and not in that part. In that part, they can be diagnosed. So if you want to catch an early melanoma, small lesions and flat lesions. So indication, inconspicuous lesions in patients with multiple nevi, and single and flat lesions with asymmetry of structure or color or a history of change, but without clues to melanoma. There is long-term follow-up, which is more than 6 months, or 6 months and more, and short-term follow-up. And you interpret the changes that you see differently, depending on the time of follow-up. If you monitor a patient 10 years, every lesion will change, benign or malignant. But if you monitor a patient 3 months, every change counts. So in short-term follow-up, every change counts. In long-term follow-up, you have to differentiate between symmetric or asymmetric increase in size. Short-term, any change is relevant. Long-term, there is only one relevant change, which is asymmetric increase in size, new structure, new color. Symmetric increase in size does not matter, or just darkening does not matter. It's not a significant change. This, for example, would be a significant change with short-term follow-up, because there is change, but not a significant change in long-term follow-up, because there is symmetric increase in size. This change would be significant for short-term, because there is change, and long-term, no matter how long you have monitored this lesion. Are there risks? Of course there are risks, because at the first visit of the patient, when you use monitoring, you take a higher risk. You lose sensitivity. Why? Because you think the patient will come back, and if he comes back, I can catch the melanoma anyhow. The problem is you lose sensitivity, and you will not regain sensitivity if the patient doesn't come back. So you only regain the sensitivity if the patient comes back. So patients are not always compliant. This is a non-compliant patient. This is the first visit. This is a melanoma, obviously, and this is the first visit. This is the second visit 3 years later. Usually we tell them 3 months or 6 months. And this is the regressive melanoma after 5 years. You can see how slowly they progress. So you have time usually. So the utility of sequential imaging depends on the compliance of the patient also. Other risks? What's the case with this lesion? Here it's a melanoma, obvious change in 3 months, but this lesion should have never been monitored. This lesion is a melanoma here, and you should not monitor a lightly pigmented nodule. You should only monitor flat lesions with a reticular pattern, but not an unpigmented lesion that is a nodule. This is a mistake. But if you follow the guidelines, and this was not among the guidelines, this was a mistake, you will pick only early melanomas, only those that are in situ. So at the end, 5 examples. On the left side, the baseline images. On the right side, I will show the follow-up image. And you have to tell me now whether you expect change or not. What do you think? Will this lesion change, yes or no? No, so no melanoma. Yeah? So what happened? The patient obviously had a visit on the beach or somewhere, yeah? Or laid under a sunbed. It just darkened. Yeah? No, but it is no significant change. Right. This lesion, what do you expect? Change or not? So you think it's a melanoma. Unfortunately, you're wrong. Yeah? It's not a melanoma. Yeah? It didn't change, and this is quite a long time, 1 year. So, but eccentric hyperpigmentation, you would monitor this lesion, but then if it's not changing, forget it. This lesion, what do you expect? So now you have become careful. Yeah? Now, change or not? Yes. What do you think is the diagnosis? Correct. This lesion, change or not? No. Who has green card, no melanoma? Do you have the green card? Red card, melanoma. So nobody has an opinion anymore. Yeah? What do you think now? And the last example. This lesion should not have been monitored, yeah? Because it's a clear-cut melanoma. And what happened? This. Yeah? So what I've showed you, and I hope to continue that at 5 o'clock, is that those lesions that we monitor are melanomas from the start. And in my second talk in the afternoon, I will attack the myth of the dysplastic nevus. Thank you.